Okay, so this video is going to be a quick, hopefully, video on an enhanced cardiac assessment for RN students. First off, part of your assessment is going to include subjective data. You're going to ask the patient, do you have or have you had any chest pain, difficulty breathing? How do you sleep? Do you sleep in a bed? Do you sleep with pillows behind you? How many pillows do you use? You're going to ask if they had a cough, and then you would follow up, all of these positive answers like, yes, I've had a cough. You would want to ask, when did it start? And then, like quality and characteristics. Is it a mild cough, severe? Is it productive? If it is productive, what is the sputum like? And so you would ask follow-up questions for any positive answers. Fatigue, are you feeling fatigued, or have you been fatigued? Cyanosis or pallor, have you noticed any blue lips or fingers or paleness? Um, Ask if they've had any swelling and where, what part of their body. And they might even know if it's pitting or not. Did you push on the swollen, when your leg swelled, did you push on it? Did it keep a little indent, or did it flatten out right away? Most may not know about whether or not it was pitting, but you can at least ask. And then, if they're going to the bathroom at night, have you had to wake up to pee? Of course, their own past history for medical diagnoses: hypertension, high cholesterol, any murmurs, rheumatic fever, anemia, heart disease. A lot of times patients won't know, but you can say, do you see a cardiologist? And they might be able to tell you they see a cardiologist, even if they think they don't have any heart diagnoses. Family history of the similar types of things: hypertension, obesity, diabetes, or coronary artery disease. You're going to ask them about their personal habits that would put them at a higher risk for developing heart disease. Do you eat a diet high in cholesterol, calories, or salt? Do you smoke? And then again, any positive responses, you want to follow it up with questions that would elicit more details to allow you to form a greater picture of how the patient is doing. Um, do you drink alcohol? If so, how much? What type? Do you take any drugs? You want to know about over-the-counter drugs. You want to know about street drugs. You want to know about prescription drugs. You want to know about supplements and vitamins. You want to know about all of it. And then, do you exercise? And I remember going to a doctor one time, and she asked me if I exercised, and then told me that being a staff nurse at a hospital was not exercise. So you want to be sure to clarify what type of activities count as exercise. So even though I was on my feet for several hours per day while I was being a staff nurse, that did not count as exercise. So your health assessment checkoff requirements for this course include inspecting for pulsations in the neck, inspecting for jugular venous distension, palpating the carotid pulses one at a time, auscultating for carotid bruits, inspecting the chest, auscultating for cardiac valves, comparing your high-pitched sounds with the diaphragm and low-pitched sounds with the bell, and counting the apical pulse for 1 full minute. So we are going to go through cardiac assessment based off of the health assessment checkoff requirements. So the first thing is we're going to inspect pulsations in the neck. So let me wait just a second for this. Here we go. Look at that. That is obvious pulsation in the neck. That is pretty significant. You're not often going to see things like that. Not to that degree. So inspection, remember, we just look with our eyes for observation and inspection, okay? How to inspect for jugular venous distension in the neck. You're going to position the patient supine with the torso elevated anywhere from 30 to 45 degrees. And we'll talk shortly about why you are not going to sit them up higher than 45 degrees, why you cannot assess for jugular venous distension at a higher degree angle than 45. You're going to remove the pillow to avoid the patient flexing their neck. You're going to turn their head slightly away from the side that you're examining, and then you'll use your pen light or some other strong light to kind of highlight the different areas of the neck to see if you can see any pulsations or shadows. Remember, bilaterally, okay? You're going to note the external jugular veins overlying the sternocleidomastoid muscle, which kind of attaches to the top of the sternum here and behind the ear, or is that in front? I think in front. Note, in some people, those veins are not visible at all, and then in others, they are full in the supine position. So as a person is raised to a sitting position, the external jugulars should flatten and completely disappear, usually at 45 degrees. That's why you can't assess for jugular venous distension when a person is lying flat. Unilateral distension of the external jugular veins is usually due to a local cause, meaning like vein kinking or an aneurysm in that one particular vein. But bilaterally distended jugular veins above 45 degrees would indicate increased central venous pressure. And so you're going to evaluate at a 35 to 40 or 30 to 45 degree angle, but there may be people that's greater than a 45 degree angle. They're still going to have that jugular venous distension, and that would indicate increased central venous pressure. So let's just look here at some of our structures. So you can see the sternocleidomastoid. It is, like I said, it has, I believe, an insertion here in front of the ear, and the origin would be right here at the top of the sternum. So you can see the external jugular vein overlies the top of that. And then this big fat one in here would be the internal jugular, I believe. Let's look at another photo or another illustration that would help. Okay, so there's your internal jugular. You can see it follows a similar path. Let's watch a video on assessing jugular venous distension. This is by actually a nephrologist, and so he does a really good job of pointing out the difference between the internal and external jugular veins.
This is the difference between an internal jugular vein and an external jugular vein. This is the external jugular vein. It is engorged, but this is the internal jugular vein with the jugular venous distension all the way up to the ear. And that is a sign of wide open tricuspid regurg. So it is very...
Okay, so you don't have to provide medical diagnoses, but he did let you know that's a sign of wide open tricuspid regurgitation. But did you see that the external jugular was large, it was full, and it was distended, but it wasn't pulsating like the internal jugular was pulsating, okay? Next, we are going to talk about how to palpate carotid pulses, which we've all done 1,000 times, but you're going to gently palpate only one carotid artery at a time to avoid compromising arterial blood flow to the brain. You're going to feel the contour and amplitude of the pulse. And what that means is, feel if it's smooth or if it's kind of like tortuous, where it feels like it's, got lumps along the way. And then it should feel like it has a rapid upstroke and then a slower downstroke. And normally the strength is 2+ or moderate, and then it would be described as equal bilaterally, or you want to check to see if it's equal bilaterally. So an increased pulse feels full and strong, and that will occur with hyperkinetic states like exercise, anxiety, fever, anemia, and hyperthyroidism. And a full and strong pulse is going to be documented as a 3+ or 4+. What 4+ might even be described as like bounding, probably too strong, okay? It would indicate there's some sort of pathology there. A weak or thready pulse would be difficult to palpate, and you would really need to search for it. It might take you a minute to find it, and then it might fade in or out, and it would be easily obliterated by pressure, meaning like you could push hard enough on a weak or thready pulse that it might disappear completely. So that takes figuring out exactly how much pressure to apply for each pulse that you palpate. So I won't have a video on this because we all have done this before. You should, as a transition student, you should know how to palpate a carotid artery pulse. So now we're going to talk about Auscultating for carotid bruits. For persons older than middle age or who show symptoms of or signs of cardiovascular disease, you're going to auscultate each carotid artery for the presence of a bruit. Now, this is part of your transitions health assessment checkoff, so you have to do it regardless of the age of the patient. If you're doing your checkoff on somebody who's maybe 40 and they're just in the hospital for some other reason, and they shouldn't be demonstrating any cardiovascular signs or symptoms, you'll still have to do this. But just know that in practice, typically that's the type of person that you would perform this assessment on. A bruit is something that you hear, and then you may have heard the word thrill before, and thrill is something that you feel, that you would palpate. But a bruit is something that you hear. So it's going to sound like a blowing or a swishing, and what it indicates is that blood flow is turbulent in that part of the blood vessel. So normally you should not hear any bruits, okay? You're going to auscultate for carotid bruits by keeping the neck in a neutral position, so not forward, backward, side to side. You're going to lightly apply the bell of your stethoscope over the carotid artery at 3 levels: the angle of the jaw, the mid-cervical area, and the base of the neck. Okay, I'm just turning my neck so you can see. You're going to avoid compressing the artery because you really could create an artificial bruit where the blood becomes turbulent because you're compressing that vessel. You want to ask the patient to hold their breath while you listen. The bruit, again, it indicates turbulence due to like a local vascular disease, and that would be something like atherosclerotic narrowing. A carotid bruit is audible when the lumen, or the inside space of the vessel, is occluded by 1/2 to 2/3 of the space, okay? A bruit loudness increases as the atherosclerosis worsens until the vessel is occluded by 2/3. And then when it's completely occluded, the bruit disappears. So just because you don't hear a bruit does not mean that there is no vessel disease. So let's watch a quick assessment video. Hopefully you were able to hear that. If not, you can Google that as well. So now that we know what it sounds like, let's watch a quick clip on what it looks like to assess for bruits.
Okay, so first let's go at the angle of the jaw. Okay, take a breath for me and exhale. Okay, take a breath for me and exhale again. Okay, again. Okay, and that sounded great. And then you're just going to compare sides and repeat on the other side.
Okay, so did you see how she allowed the patient to inhale and then exhale, and then she gently placed her stethoscope on the neck at that point? That's what you want to do. Next, we're going to talk about how to inspect the chest. You have to remove the gown. You have to inspect with your eyes, and you can't do that if the patient's gown is covering their chest. A lot of times people want to just like peek down the gown and see what they can see. But for a good assessment, you're going to have to remove the gown. You can protect patient privacy by having the door closed, the curtain pulled, by untying the gown at the back of the neck and pulling it down. And that allows the client to be covered on the bottom half of their body if they're male. You could also inspect from looking down on a female patient, or like remove the gown from the side to allow for privacy. Now, you may or may not be able to see the apical impulse. When it is visible, it's going to occur at the 4th or 5th intercostal space at or inside the midclavicular line. So here's your clavicle, midclavicular is like halfway, and then down to whichever intercostal space you're looking at. So it's easier to see this in children and people with thin chest walls. So a heave or a lift is a sustained, forceful thrusting of the ventricle during systole. It occurs with ventricular hypertrophy and is seen at the sternal border of the apex. I could not find a video that showed a visible heave or lift, but I do have a short clip that talks about how to palpate for that.
Parasternal area. You look for a lift or a heave. تحط يدك كده and I feel for something lifting my hand or heaving. Okay? So
Okay, so he's saying like if you palpate, you can feel like something lifting or heaving. Next, we're going to talk about how to auscultate cardiac valves. First, you want to identify the auscultatory areas where you will listen. They are not over the actual anatomic location of the valves, but they are located where you can hear each valve the best. So at your second right interspace, you've got the aortic valve, second left interspace, the pulmonic, left lower sternal border is the tricuspid valve, and then at the fifth interspace, around the left midclavicular line, you're going to hear the mitral valve area. And then, of course, there's Erb's point. So let's take a look at some of these. You can see in this illustration the location, the anatomic location, and then you can see where you will hear those different valves. You don't have to listen just in one spot. You may end up moving your stethoscope around a little bit, and that's completely okay. If I have a student that puts their stethoscope down and they hear everything perfectly, and they tell me that they never have to hunt for a better sound for each of the valves, I'm going to question whether or not they're doing a good, thorough assessment and listening for what they need to listen to. I've done it multiple times where I'm listening at one spot and it's really kind of difficult to auscultate, and I'm not certain if what I'm hearing is very clear. So I might slide my stethoscope around a little bit and take my time listening. There is no good reason to be too fast for a proper cardiac assessment. You're going to take your stethoscope and you're going to clean your diaphragm. You're going to listen and you're going to identify the rate and rhythm of the heartbeats. You're going to identify S1 and S2, and you're going to assess them separately for quality. You're going to listen for extra heart sounds like S3 and S4, and then you're going to listen for murmurs. So that's multiple steps. Identify your rate and rhythm, identify S1 and S2, assess them separately, listening for the quality, listen for extra heart sounds like S3 and S4, and then listen for murmurs. So what are the heart sounds? S1 is a lub dub. It's the closure of the AV valves, and it's the first part, the lub. Then S2 is the dub, or the dub. It's the closure of the semilunar valves. So I have a picture here that shows you your semilunar valves are the aortic valve and the pulmonic valve, okay? So that's the S2 when those two valves close. Then both of those two heart sounds are going to become diminished with conditions that cause any increased amount of tissue between the heart and your stethoscope. So emphysema, obesity, and pericardial fluid will make those sounds more difficult to hear. Your S3 is a lub-dubba, where there's a ventricular filling sound or a gallop, and it's heard best at the apex with the patient in the left lateral position. And then an S4 is like a ventricular filling sound that's heard just prior to S1. And again, it's heard best at the apex with the patient in left lateral position. You've got to have a good stethoscope with a good bell and good condition, and you've got to really listen for these. Let's see if we can get our video to play for us. I'm going to let this one play for a while. Read the words and listen carefully. Okay. Now, please note when you document things like an S3 or an S4 or a Gallup or an extra heart sound, you don't have to provide the diagnosis. You just have to be able to recognize that you're hearing extra sounds and document what you're hearing. Next, we'll talk about counting the apical pulse for 1 full minute. You want to localize or locate the apical pulse precisely using 1 finger pad. You're going to note that it's usually in the 4th or 5th intercostal space at or medial to the midclavicular line. So there's midclavicular, and then medial to would be slightly more towards the center. Usually it's only 1 centimeter by 2 centimeter in size, so you have to be fairly precise. And the amplitude is just usually a short, gentle tap. Usually it only occupies the first half of systole, so it's short. The apical impulse is palpable in about half of adults. It's not palpable with obese people or people with thick chest walls. In high cardiac states or hyperkinetic states, like I talked about earlier, which are anxiety, fear, hyperthyroidism, and anemia, the apical impulse increases in both amplitude and duration. We used to call the apical pulse the point of maximal impulse, or PMI. So if you ever see that, that's what they're talking about with that. So that concludes the assessment pieces that you are responsible for the transitions clinical health assessment checkoff, and hopefully provided you with a little bit more information about what you're hearing or what you're assessing for and what it means. Thanks so much. Bye.